Okay, so we're in the second session now after this short interruption. We go now with the lecture of Professor Michalis. It is...
Good afternoon.
Hello. Nice to hear you at the moment, and I hope to see you.
I thought you can see me. I'm here.
Yes. Okay. Hello.
Right.
Nice to see you.
Hello. Nice to see you.
Okay.
Do you want to share the screen or do you want to listen the recorded one?
It's up to you.
I prefer to share the screen.
Okay, it will be greater. Okay. So, Professor Michalis will...
Can you see it?
Yes, excellent.
Great.
Excellent.
First of all, I would like to thank you for inviting me and to say how sorry I am that I'm not with you there. But I'm still recovering from COVID and I'm not in my best sort of shape. Anyway, let's start. First of all, when I got this message to talk about small vessels, I have to, and when and how to address them, I have to admit that I found it very challenging. And that's because after sort of being in the interventional cardiology for quite a long time now, I always thought that small coronary vessels is a very challenging thing. And there I try to summarize all my concerns and that I've got over all these years. But I'm not going to go through with all this through you now. But let's start one by one. First of all, what we see, what we think, when we're saying about small vessels, what the small vessels are. Going through the literature, you can see different definitions. One very obvious is that a very small vessel is something which cannot be treated with a stent, because we don't have so small stents. Another is when it's less than 2.5 millimeters. Another one is when it's less than 3. So if you take all the literature, what you get from the results, it depends upon what definition you used when you spoke, when you defined small vessels. And after all these years, we're still struggling for a definition. The second thing is, do we really see small vessel disease in our everyday practice? Is that a problem? And I have to say that almost 1/3 of our patients that we do every day, if we think we see small vessels, and which puzzle us, and we don't know what exactly we can do with them. And it's not only that we see a disease, a sort of a lesion in a small vessel. Usually it's not just a simple angiographic lesion. It's a diffusely diseased vessel with lots of calcification. And not only that, it usually goes with diabetes, female gender, and older age. So in patients that they have many comorbidities. So small vessel disease is a frequent problem. We face difficult lesions and also we face difficult patients. But when we are talking about small vessel disease, if we start thinking, all of us, the first thing that comes to our mind is that is something that affects distal coronary segments. But it's not always the case. Sometimes we see small vessels, less than 3 millimeters, even in middle or proximal coronary segments, which possibly they look small either because of diffuse stenosis or because we have the vessels have a very severe negative remodeling and they are small because of that. And that usually happens when we see CTOs. So small vessel disease is heterogeneous disease, might affect distal coronary beds or small branches, or might affect more proximal segments with diffuse atherosclerosis or segments that they have severe remodeling. And because it's heterogeneous disease, we can't say that we have one solution for which can fit to all of our patients. And how can we decide if a vessel is small or it's just looks small? And is that an often problem which we encounter quite often? It seems that it is not something that is rare. About 17% of our patients, definitely the vessels are much bigger of what we see, and they are not small. And usually that, so when we see something which is in the mid segments or proximal or a CTO, it's better to interrogate with intravascular imaging in order to know what exactly the size of the vessel is. But when we go further down the coronary tree to do intravascular imaging, although it could be useful, it's very difficult for obvious reasons or maybe risky. Another question that we have to answer to ourselves when we face this disease is that do we have to treat it interventionally? Well, if we have a stable coronary syndrome, then we know that the majority of our patients will not be benefited in the case of survival from interventional procedures. So we have to be careful why we treat these patients. And this is what is shown in the guidelines. When we treat patients, we treat them either for prognosis or for symptoms. And mainly, the small vessel disease is for symptoms. It's much rarer to have to treat somebody on prognostic grounds. So it's obvious that there are certain patients we have to choose, and we should not treat interventionally all of them. So how can we choose them? The main thing is symptoms. The second is FFR. FFR is something that I always have a sort of a different opinion what it shows, and for me it does not show ischemia or less ischemia, mainly shows prognosis. So we can choose who is going to have an advent event and a MACE because of that disease. And if we go through that, then it's good to use the FFR, and because it's sometimes it's difficult or it's expensive. Now with the new angio FFR, we can improve we can use it more freely, and possibly we can have good results. So we choose our patients because of symptoms, and if we go to use it for functional hemodynamic assessment, then we can use FFR. I don't use intravascular imaging to choose a patient. I don't think that's a very good correlation between the size of the vessel and the FFR, so I don't like to use it for this kind of reason. I use intravascular imaging only if I'm going to have decided that this patient has to be treated, and if I want to plan my procedure, how big the vessel, how big the stent is going to be, how long it's going to be, when I'm going to find a good landing zone, or to assess the outcome. And when I use the FFR, I don't use small vessels. I don't go for the 0.81. I go for the 0.75 because I think that is much more sort of a stronger indicator of prognosis than just 0.81. Then another thing that we quite often face is that, okay, if you have a stable coronary patient, it's all right, you can go without intervention, but what if you have somebody who is an acute coronary syndrome patient? And we know that acute coronary syndromes, they don't do very well. So one of the things that we have to sort of start questioning ourselves, can we identify patients that have acute coronary syndromes and they will do quite well with stronger antiplatelet treatment? And it seems that patients that they have just an erosion and not a rupture in the plaque, possibly they can do quite well. How well? not very well, but that is what it is. It's about a 6% mortality during the next year. So it's not very good thing to go medically, but sometimes this can be one of the options which should be considered in case patients who have acute coronary syndromes. And why we don't like very much to do something on these vessels? We don't like it very much because small vessels treated interventionally do twice as bad compared with the regular vessels, because they have restenosis, because they have possibly you can create acute thrombosis of the stent. There are long stents, small stents, restenosis, thrombosis, or even perforation. And is there any way that we can improve our results? Well, if you decide to go for this vessel and you put a stent of 2.5, then it's not a bad idea to have an IVUS, to interrogate the vessel, to interrogate the result, and do whatever is needed to improve your outcome. And it seems you can gain something through interventional imaging in this type of lesions. These are all the studies and all the evidence, more or less, which have tried different ways of revascularizing small vessel disease. And if it's a small vessel, what they say is that just a pompa possibly is enough. Small vessel, less than 2, we don't have a stent for this type of vessel. We cannot use drug-eluting balloon for this type of vessel. So just a small vessel, just a small pompa may be a good thing just to do, go out of it. And all this concern about the stents, why is all this concern? Because we need long stents, distal coronary beds, which possibly then restrict our options in the future, because we have calcified lesions with suboptimal stent results, not optimally deployed stents, and because we have the fear of perforation in this small vessel, which then is difficult to be treated because of the size of the vessel. So the next thing which has come into our lives nowadays is the drug-eluting balloons. So is drug-eluting balloons an option for this type of patients? Well, definitely is an option, and the latest trials show that at least they are not inferior compared to the drug-eluting stents. Having said that, the big registries show that they are rather inferior, and that's mainly because of restenosis. This is the main problem that we cannot address very well with the drug-eluting balloon in small vessel disease. So if you have somebody who has already in-stent restenosis, drug-eluting balloon is something that drug-coating balloon is something that we can think, and it's a very good way of treating it, trying to avoid to have lots of layers of metal inside the stent. And if you have somebody that you need to shorten your drug-eluting therapy down to 4 weeks, and it's a long lesion with a small stent, is a stable patient, then again it's a very good idea. And definitely for everyone, it's not a bad idea to do it. And we'll show an algorithm further down how we can consider using them. What about bypass grafting? I wouldn't think of that in the small vessels, and I'm sure that the surgeons they will hate me if I offer this type of patients to them. So let's go to this small algorithm, which what it says that if it's more than 2.5 the vessel diameter, then it's okay, use a stent. If it's less than 2.5, think of a drug-eluting balloon in case that you have an optimal result, that you haven't had dissection, and you have a TIMI-3 flow. But having said that, there are many patients that we fail to achieve this type of result after using a balloon dilatation. I'll show you exactly how it looks like when you try to treat this type of patients and how you can start and how you can finish And this is a patient that had a CABG in 2008 with the lima in the LAD, RIMA and PDA, radial in diagonal and the jump grafted obtuse marginal. He had the PCI on the right coronary artery and PDA through the RIMA in 2019. He's a smoker, and now he comes with an acute coronary syndrome with a not moderately impaired left ventricular function. And this is the type of the vessel that we faced, and that was the vessel which caused the acute coronary syndrome. In this case, you can see a diffusely diseased vessel, proximally, distally. You can see the patent lima to the LAD, good vessel. And this is the patent RIMA to the right coronary artery, who has already had a stent on it. So what to do? One thing is to try to stop there and try, as we spoke before, just with a potent antiplatelet treatment. The other is try to do what we said that we can do, try to treat it with balloons, try to put a stent here, and then just leave it there with drug-coated balloons. And that was our initial plan. We tried with a balloon here, 1.5, couldn't cross the lesion easily. We went to the other part, we put a balloon there. We pre-dilated the proximal part. We came back again here after we tried, and now we crossed with a small balloon. And now we achieved what something would expect, that here that we were expecting to put a drug-coated balloon, the vessel was dissected. So now we have to put a stent down there, long stent, 2.25, good result. Well, I insisted to open that and put a drug-coated balloon according to the plan. And now it seems that didn't achieve a lot. Try a bit again. And now I managed to sort of dissect this vessel as well. So I can't go according to the plan. And now I have to put stents in there. So what I tried to do actually was to put stents where cover the dissections and leave this proximal bit there, so don't get into the bifurcation with the stents. Try to avoid as much of the problems with the stents. It seems that I managed to achieve it. And I can put a stent there just before the bifurcation, which is this 2.75, is a much bigger vessel. I expected that. And that looks good. And look good after the IVUS, which I'm not going to show it. And I left this just with drug-eluting balloons in that part, hoping that we will notice the nose. It's always a struggle treating this type of vessels. I'm not so sure how good that is good for a patient. I hope that I've done my best and I offered him a solution. He remains asymptomatic. For the time being, he's okay. But this is what I see is the problem with the drug-eluting balloons. So revascularization for this type of patients, in symptomatic patient, PCI, because of the diameter and the length, is not the optimal thing. We can try to use drug-eluting balloons, but we have to have a good result after the balloon and don't have a dissection. And if it's a really small vessel, then we can only use a small, just an ordinary balloon angioplasty. Thank you very much.
Hello,
Hi.
Dr. Michalis. Can you hear us? Yes.
Yeah, I can hear you very well.
Excellent presentation. Thank you very much for presentation. Any questions from the panel? Okay, I have a question for you.
Sure.
Do you think, according to data that you showed to us, do you think that we should completely shift to drug-coated balloon when we deal with such a small vessels?
We can try, but that's what my message was, that we can try, but quite often we don't achieve because you have dissections. And the problem with the stents, just thinking, you're much younger than I am, but when we start, Matip is my age, I suspect. But when we started with the stent, the idea wasn't to reduce stenosis, it was just to go back home and have a quiet night and not have a sort of acute occlusion overnight. And when you see this dissection, you never know how it will end up. And that's why we started putting the stents, and then the beginning was not quite often, then went up to 35%, then went up to 50%, and jumped up to 100% when we had these results that it reduces stenosis as well. But the ordinary stents, especially, they reduce stenosis in big vessels, not in small vessels. And more or less it's the same for with the drug-eluting stents. So when you see a dissection, that's where the problem is. How can you know that that will go well and that you will not bring you overnight try to open it again, which is going to be a rather difficult thing. And it's because we went through that phase, I'm telling you that you never leave it, when you say dissection, you never leave it alone. I know that if it goes well, it will do very well, and it will have possibly a very good remodeling, but how can you know? Anyway, I do my best to use them. You have to have a bigger vessel around 2.5 with the existing balloons, but it's not always an easy thing to do. For in-stent stenosis, definitely that's a good case there. For the diffuse vessel disease, it's more difficult, although we have to try.
Thank you. Thank you very much.
I just have a comment. You really opened my eyes about this small vessel disease because it's an entity that we don't often discuss and not very often discussed in the literature. You made a very important point about negative remodeling. We see that in CTOs where you open up the proximal CTO and the distal vessel looks small. And you might see a similar finding in a severely stenotic but non-CTO vessel where the distal vessel is small. And one might assume that there is diffuse disease and the vessel is small. And often you bring these patients back and you find that the vessel has now remodeled to its original size. It looks very good. So some of us have to avoid the temptation in CTOs and severe stenosis when you see diffuse narrowing distally, just avoid trying to balloon or stent distally of every lesion that you see because it may not be the right thing to do, correct? So you fix the proximal lesion, right?
Yeah, that's good. Yeah, that's true. That's true. And this is something that we sort of knew that from a long, long time, but before the stents.
Yeah,
we
correct.
knew that, and then we have forgotten that.
Yeah,
and now we rediscovered it.
Yeah,
especially with the CTOs, how well the sort of the coronary bed sort of behaves itself quite often when you leave it alone and just you pump it with blood.
Right.
And
right.
there's no way that you can open a negatively remodeled vessel and you can open it. Only nature can do that.
Correct.
And we don't have the tools to open it, and we have to leave it alone and see how it behaves. And usually these type of vessels, if you don't try hard, they don't dissect either. They dissect if you try hard. So try to avoid to dissect. And usually, sometimes they don't dissect, they perforate if you try hard. So just leave them alone and to take their own course and see how it will go.
Yeah. Thanks for those comments.
I have also a comment, Lampros.
Yeah, sure.
We know that there is a relationship between the diameters, the length, and the flow in a vessel and the amount of supported myocardium. So for bifurcation, Bonkonku proposed to define what is a vessel which is supporting more than 10% of myocardium. So treated, this vessel will have will improve the survival of the patient. So, as you said in several occasions, it's difficult to know the relationship in a patient, to know the relationship between the diameter and the clinical result. Because this is diffuse disease in diabetes, because this is remodeled in CTO. So, Bonkonku tried to define a value that tell us in diameter, that tell us this is a vessel supporting more than 10%. And he failed. But he looked at the length of the vessel distal to the stenosis and the disease vessel. And he found that more than 73 millimeter in length is a vessel which is supporting more than 10% of myocardium. So this can be an alternative. If a small, long vessel, maybe these ones can be treated. If they are small but not long vessel, leave them alone. I'm not a fan to treat small vessel like you.
Just 2 comments. Dr. Michalis, did you have some experience with the scoring balloons in small vessel disease?
Well, I have. One of the problem is that what is the size of this scoring balloons? Again, it's not for small vessel less than 2.5.
Yes, but
the second
at
is
the moment
if it's
there is
distal. If the second is if it is going if it's a sort of a distal segment, will you be able to get there? Again, that's another problem. Scoring balloons are awkward balloons. If you manage that, I found them very good for fibrotic lesions. Fibrotic lesions like the one that I don't know we've seen in the lecture before, in the middle right, they are very good the scoring balloons. If it is for the other lesions, it's much more difficult. I have to say that the scoring balloons, which they exist much longer than the stents, if I remember well. Am I right, Yves? Cutting balloon, it was
yes.
before the stents.
But this is
reason
cutting.
why, yeah, the cutting. Well, okay, that's one of the first one which appeared was the cutting, and there was another one which was more like a scoring balloon, which had a wire on one side, the orbus or whatever was called those days.
Yes, it's Corflex.
It was because we wanted to create a controlled dissection. And having a controlled dissection, then we will not have an acute vessel closure. So if you manage to go there and you manage to create a controlled dissection, it's a good thing. It's not always easy to get there with a scoring balloon or a cutting balloon. They don't track so easily. That's one of my problems that I face.
I see.
And definitely you will need a bit of a pre-dilatation. You know, for example, if you see that obtuse marginal that I treated, it wasn't easy to get there with a cutting balloon or a scoring balloon or whatever you want.
It's good that actually the technology improves, and there are some several new scoring balloons with much better profiles.
Better profiles, but they do less cutting.
Yes, it's well. Obviously there is some balance between these two entities, but
Definitely there are no any trials sort of comparing what the results would be in this type of vessels. We have to say that.
there are some ongoing trials.
Yeah,
Just
but we don't have any results.
on these techniques. Regarding the comment of Eve, I would like to say that the length is more important than the emitter when you define the area at risk, let's say, so from for some vessels, and we, not only we, but there are several studies which clearly demonstrated that some small vessels, so-called small by diameter vessel, but long as a length vessels, are very important. Actually, this is much more important than the diameter, and probably that should be involved in the decision making in future, because at the moment we are almost entirely, as this figure which at the beginning of your presentation you demonstrated about the algorithm of decision making with the size was actually entirely based on the diameter of the vessel, and this is because of the balloons we have.
And that's why actually we use the FFR as well, because the FFR, the longer the lesion is, the lower the sort of the number of FFR that you will find. The shorter the lesion is, even if it's sort of eyeballing or with QCA, very severe lesion, you might have a very good FFR, and we can see that even in the sort of after putting a stent where you pinch sort of a vessel and a side branch, and you see sort of a very sort of severe stenosis, but still you've got a good FFR. Even in the proximal circa, in the ostial of the circa, when you can still have a good FFR after you have a sort of a rather severe, if it's a short lesion. The longer the lesion, then the less the FFR value that you will face. And for me, FFR and what this value says is that it's a prognosis of future events. And the bigger the area at risk is, the bigger the problem will be for the patient.
And maybe this is the most important message which we have now. This is really should be underlined. Okay, so thank you so much, and I think yes, we are just in time, and I would like to ask you to stay online.
Yeah,
Dr.
I'm
Michalis,
here.
just
I've been
about
here since
yes.
I've been the whole morning. Don't worry.
Okay,
I'm here.
it's great just to be involved in the discussion after the lecture of Professor Nair about the dual antiplatelet therapy and high bleeding.
Sorry about my cough, but here you are.
Yes, it's understandable.
Yeah, get better from your COVID.
And the problem with this COVID is that you're negative and you don't have any fever, but still you suffer. You know, it's a funny thing. It does not leave you alone for quite a bit of time.
Yeah, and you have to stay at home from everybody else. Anyway, so go ahead.
I'm negative. Don't worry. Even if I was there, you would be sort of be in danger of me. Or that's what I hope anyway. All my tests now negative, but still
good.
Cough.
Yeah. Anyway, so slightly change in directions where I'm going to address the role of dual antiplatelet therapy in patients who have high bleeding risks. So we have been using DAPT for quite a while, and historically we have known that DAPT has always been needed to prevent in-stent thrombosis, which is associated with significant cardiovascular mortality and morbidity. Initially, when we placed bare metal stents, we knew that they endothelialize rapidly, reducing the thrombogenicity of these stents, and so 30-day treatment with DAPT was enough to prevent in-stent thrombosis in bare metal stents. But these stents are rarely, if ever, used anymore. Then along came DES, and the older generation DESs are not really used anymore. And our techniques over the years have evolved. And the comment I can make about the older generation DES and our initial techniques that we used to deploy stents was it required the use of DAPT for a year, and sometimes some studies have shown even up to 3 years to reduce the risk of in-stent thrombosis. It's not in-stent restenosis, but to reduce the incidence of in-stent thrombosis and myocardial infarction and death. However, over that period of time, our thinking and the treatment with DAPT has continued to evolve. This trial that was published in 2014, I just bring up not as a suggestion or recommendation as to what we should do today, but again pertaining to the historical perspective of DAPT. So published in 2014, it was noted that DAPT beyond 1 year after placement of DES as compared to aspirin therapy alone reduced the risk of stent thrombosis. So we went from 1 year to beyond 1 year, and it reduces the risk of cardiovascular cerebrovascular events, but was associated with an increased risk of bleeding. It was seen that predominantly the myocardial infarction and cardiovascular events that occurred was due to stent thrombosis in these patients. So it was felt that this prolonged DAPT was important. However, this was associated with increased bleeding. Since then, what has happened? We are now in the era of stents that have much thinner struts, which have much less in terms of surface area. In addition, the components of these stents are very much less thrombogenic. The polymer that coats these stents has changed in composition, and there are some stents that have biodegradable polymers, both of which then reduce the inflammation, platelet aggregation, and thrombogenicity of these stents. The drug itself has changed, evolved to a much more benign drug. In fact, paclitaxel is out, not being used anymore. They're all Olamus stents. And because the stent struts are smaller, the surface area is less, the amount of drug dose on these stents is also markedly reduced. Again, perhaps reducing the local inflammatory effect of these stents. Importantly, we have also over the years begun to understand how we optimize stent placement with our recognition of high pressure balloon inflations to deploy the stent, accurately measuring size of the vessels with better imaging techniques, and the use of intravascular imaging, which allows optimal placement, sizing, expansion of stents. So all these potentially have decreased platelet deposition, inflammation, and thrombogenicity, potentially lowering stent thrombosis and MI. And this has been seen in the current literature where the incidence of cardiovascular events due to in-stent thrombosis is markedly low. The other thing we have recognized with the use of DAPT in many patients is that DAPT-associated bleeding is just not bleeding alone, but actually increases the cardiac-associated mortality and morbidity. So that if a patient becomes anemic, ischemic syndromes become rampant. Second, type 2 MIs become common. And also bleeding and transfusion increases the coagulopathy, causes clot formation, and myocardial infarction of either of native vessels or the stented segments clotting off and causing myocardial infarction. There have been studies now in the literature which have looked at shorter duration of DAPT and has been published. And with these recent studies, with stents there are thinner struts and better polymers and drugs, 6 to 12 months of DAPT can now be recommended. And so the guidelines that were published in 2016 and the European guidelines are very, very similar, suggests that aspirin should be continued, and in a class 2B recommendation is that in patients with stable ischemic heart disease, we will ignore the BMS, who are not at high bleeding risk, you can treat patients for 6 months or even longer. So this is where the 6 months data has come. However, in those patients that are at high risk of severe bleeding, discontinuation of P2Y12 inhibitors can be discontinued in 3 months. So slowly we are evolving to less and less duration of DAPT. In patients that have acute coronary syndromes, obviously the incidence of recurrent MIs and acute coronary syndrome is reduced if DAPT is continued for a year. So this has to be taken into account in addition to the placement of stents, and it may be reasonable to then continue it for 6 months because of the risk of myocardial infarction in patients that have an unstable coronary syndrome. And that's mentioned here. So in patients that have stable coronary syndrome and high bleeding risk, 3 months are okay. However, in patients that have had STEMI or NSTEMI, where the incidence of repeat events are likely to be high, you can choose to go 6 months. However, even with the reduction in the use of DAPT to 6 months or a year, there are many issues that have arisen with this kind of long DAPT therapy. In the sense that 40% of all those patients in whom DAPT is indicated, they have high bleeding risks. So nearly half the patient population that we treat in whom DAPT is indicated have a tendency to bleed. Moreover, emergency or urgent surgery will pose a risk of perioperative bleeding, clearly because patients are on DAPT, and the surgery, because it is urgent, cannot be postponed, such as hip surgery, fracture correction, intracranial bleeds, etc. This is a problem when you continue the DAPT. If there are surgeries, operations that are indicated, then these have to be postponed for a period of while. This is very, very crucial in cases of cancer surgery when early surgery is indicated to reduce the incidence of the cancer progressing. If a patient were to have trauma, acute trauma, like a motor vehicular accident, fall from a ladder, etc., this increases the risk of bleeding complications and may result in increased mortality. What has also been seen is that these patients, if they bleed, their risk of both cardiac and non-cardiac mortality is increased. So when you look at all of these criteria, it is important to know that further decrease in DAPT duration is warranted. However, this has to be balanced with us not risking stent thrombosis, which of course can pose its own problems. So with this in mind, the Zions 90-28 3-month and 1-month therapy was undertaken in those patients that had stable ischemic heart disease and underwent stent placements. These were patients who were at low risk, did not have STEMI or NSTEMI, and the lesions that were treated were felt to be low risk. Left mains were left out, vein grafts were left out, multiple overlapping stents were left out, CTOs were left out. So these were less complex lesions. And they looked at non-inferior ischemic outcomes. And what was seen is that with the reduction in duration to 1 month and previously 3 months, the ischemic events were equal to the ischemic events seen in 1 year, whereas the risk of bleeding was markedly less. So with these current generation stents used in the right case scenario, you could decrease bleeding without increasing the risk of ischemia in these patients who had that stent. What is interesting to see is that when patients did have cardiovascular events, that the rates of in-stent thrombosis was actually low. So the events were mostly dictated by patients' underlying disease rather than the presence of stents. The second caveat here is that the P2Y12 inhibitor, either clopidogrel, ticagrelor, or prasugrel, was discontinued, and in a majority of patients, it was just single antiplatelet therapy with aspirin. So that's very important to know. More recently, this data that was published for the first time in the European Heart Journal looked at patients who underwent stent procedures even in the high-risk situations, vein grafts, STEMIs, end-STEMIs, CTOs, bifurcation, multiple stents, triple vessel, etc., was used, and recurrent ischemic events beyond the 1
Между другото,
month.
аз чувам само с това ухо. С едното не чувам.
Excuse me?
Не. Вас не ви чувам. Ако не...
Sorry for that.
Айде.
I'm sorry, somebody is speaking over me.
Yeah, it's from the cat lab.
Yes,
So sorry.
yes, that's all right. So, but this obviously were in patients that had high bleeding risk, and we'll define the high bleeding risk, but the ischemic events were markedly low. In this study, as opposed to the Science 9028 study, I repeat, these were patients that are high risk for stent thrombosis because they were complex lesions, clinically as well as stent placement-wise. These were complex lesions. And more importantly, the antiplatelet agent that was predominantly discontinued was aspirin. So either clopidogrel, ticagrelor, or prasugrel were the drugs that were predominantly continued over the next year or so in these group of patients, and despite that, the bleeding risks were very low. So what recommendations can we make today? So we have to weigh the bleeding risks versus risk of cardiovascular events. So if we choose all patients that have high bleeding risks, and we have to define what they are, and those patients that are high risk of cardiovascular events and balance the two, then we come up with an optimal regimen. So based on the last two studies that I mentioned, either aspirin or P2Y12 inhibitor can be used as a single agent. And let's see when we can do that. So what are those patients that have high bleeding risk? These are some of the criteria that have been used in various studies. Patients that have bled before, a lot of our patients are on oral anticoagulation, either for valve disease or atrial fibrillation, females, advanced age over 65, low body weight, kidney disease, diabetes, anemia, other medical therapy, and hematological conditions all pose, in some people, high bleeding risk. Versus who are the ones that are at high ischemic risk? Advanced age, kind of acute presentation, either STEMI or end-STEMI, multiple prior MIs, and extensive coronary artery disease, diabetes, and kidney disease all pose risk of increased stent thrombosis. There are very many scores that have been used. DAPT score is one of them, and you can look at it as well as I do. And if you have more than 2 points, it favors it is a favorable risk ratio, whereas if it is less than 2, then there is unfavorable risk of for prolonged DAPT therapy. There are other precise DAP score that you can obtain online. You can calculate the advantage and disadvantage of prolonged DAPT therapy. So as I said, as opposed to the bleeding risk, there are some clinical scenarios that pose high risk of stent thrombosis, and one might anticipate that stopping DAPT might pose risk of stent thrombosis and myocardial events, and these are some of the features that pose a risk for high stent thrombosis rates. So what's the take-home message? So we have decided which patients are at high bleeding risk. We have decided which patients are at high risk of stent thrombosis. The guidelines are not out yet as to what we should do with 1 month or 3 month DAPT therapy. So my take-home message is that there are a significant number of patients on DAPT that are at high bleeding risk. So we need to curtail DAPT therapy in these patients because bleeding poses high mortality, both cardiovascular and non-cardiovascular mortality in these patients. So though the guidelines mention DAPT for 3 to 6 months, those patients that are at high bleeding risk, this has to be evaluated further. And we are moving towards discontinuing P2Y12 inhibitor in 1 month in patients that have stable coronary artery disease. How about those patients in whom we have done complex procedures or the presentation was more complex? One of the studies that I mentioned suggests that stopping the aspirin reduces bleeding risk but does not increase the risk of stent thrombosis. So DAPT omitted, but one antiplatelet agent used. So when we approach these patients, one needs to balance bleeding versus ischemia risk before recommending either prolongation or short duration of DAPT therapy. That's the end of my presentation. Thank you very much.
So, thank you, Professor Nair. This is a topic which we can discuss maybe several days. If you
I
go,
hope not.
if you go into the details. But what is your opinion about the so-called de-escalation therapy? I mean, switch from the more potent inhibitors, ticagrelor and prasugrel to clopidogrel. What is your personal opinion?
So the strongest data is with patients with STEMI and NSTEMI, where ticagrelor is indicated for a month, whether you put a stent in or not. And prasugrel, of course, has contraindications, elderly patients, patients with kidney disease, etc. But in Plato, if you look at Plato, then the prognosis is better if you use prasugrel in these patients with acute coronary syndromes. However, in patients that have high bleeding risk, you can start these agents and then de-escalate to clopidogrel. I think that is the better advice to reduce the risk of bleeding. So in patients with intracranial bleeds, of course, kidney disease, prasugrel is never going to be used. In ticagrelor, you have to use in care. So those criteria that I've laid out for patients with high bleeding risk, I think going with clopidogrel and aspirin in the first month and then continuing either one, depending on the complexity of the case, is good. And I think that is the de-escalation I would talk about. It depends on the clinical syndrome, because if you look at guidelines, patients that have an NSTEMI, STEMI, ticagrelor for a year is preferred over clopidogrel, but they don't really mention whether it is patients with high bleeding risk.
Exactly. Actually, the high bleeding risk patient is a subpopulation which is,
yes.
First, it is not rare, right, unfortunately. Actually, every patient at age more than 75
right,
is already, because of the age, in the high bleeding risk patient, and taking into account the aging of the population in general, these patients are more and more appearing in our practices. So this is why we should to improve the strategy, how to basically manage this patient. I think, Nikki, what is your strategy in your center?
Yeah, I have a question for Professor Nair also, but it's according to our strategy. What do you think when we have an extremely high bleeding risk patient to use the strategy nothing left behind? I mean, to use drug-coating balloon. I'm feeling really comfortable to stop the second antiplatelet agent if the patient needs.
Yeah.
And I think this strategy should be taken.
Unfortunately, in the US, we have no experience with DEB. So one of the problems planning DEB is like in the last case, you try a DEB in certain situation, and you have dissection, and then you are in trouble. Very hard to treat severe left main stenosis, proximal LAD with balloon alone, and should you have a dissection, then you are in trouble. So I don't think going in there saying I will just treat with DEB. I'm no expert because I have not used DEB. We don't have DEB. I wouldn't plan on doing that in the beginning.
We are, in our center, we are
Yes.
using more and more in different cases, different anatomical and clinical scenarios, drug-coating balloons. And we found that it's a majority of the cases we can reach, let's say, acceptable results.
Yes.
And safe for the patient. And we are feeling really more comfortable to leave the patient on single antiplatelet therapy, and that's enough.
And even short duration of therapy, right?
Even short duration, that's for sure. But if the patient it's at extremely high risk, that's an option.
Yeah.
Robert Gill has a special terminology about this. I remember in 2007 when I had to do one long lesion in the circumflex, and he told me you should do that with the balloon, and I said, how? And he answered, delicately. You should make a delicate PTCA, only with the balloon. You should not put stent here, do it by balloon. And sometimes, yes, one person?
For me, actually, the best strategy is to try to perform a technically optimal angioplasty.
I agree with this, yeah.
Because how we ended up into this problem? We ended up with this problem because we thought that we can do a very quick, not optimal sort of angioplasty, and we get away with a longer antiplatelet treatment and longer and stronger antithrombotic drugs. And the idea is we thought that kind of angioplasty was in the beginning was a very long, very sort of demanding procedure. Then it became a very quick sort of a procedure that you can treat, everything can be treated, even you don't need to pre-dilate, you don't need to treat, just put a stent and everything will go right. Now we understand that we have to spend a lot of time, effort and money when we try to treat patients interventionally. And we managed to, with the new stents, we managed, then we had the drug-eluting stents, which we realized that it was sort of a double-edged sword. Now we proved that technology, and now we know that we can shorten the duration if we have a good result, at least. But what it ends up is that we treat more and more difficult patients that they need longer antithrombotic treatment for their own native vessels.
Yeah, correct. Correct.
So it's not that we can stop that for the stent.
Correct.
But still we need the long antiplatelet or antithrombotic treatment for other reasons.
Correct.
Yeah. And the other point is that I think that with we a little bit just forgot how to do a good balloon angioplasty. Just there are
we never knew.
I remember because yes, maybe I'm not so young as I look on outside, but anyway, I think that
And don't
there are,
forget, and don't forget that we have now more difficult patients, and the type of lesions that we are facing, they have nothing to do with
Absolutely.
we used to see before.
absolutely.
Now, if you ask me why, we have to find the reason, and I personally believe it's because of statins. Statins. I'm not saying to stop giving statins by any means, any wrong. But what we have is we take all the lipid out of these lesions, we make them stable, but we do them very calcified in the end. So patients will live longer, they will present later, possibly, I don't know if with acute or not very acute events, because many of what we call now acute coronary syndromes, in the old days, we will never have diagnosed them because we didn't have troponin. And the majority of these patients that we call nowadays MIs, if we do a CK or a CK-EMB, you will say that they have unstable angina or nothing. And possibly they would have never gone to the cath lab before. And but the type of lesions that we face, they're really very tough. That's the problem that we face. And also, what another thing that possibly you or I don't know, if definitely have seen the old stents. In the old days, we used to say that if a stent does not reach the nose in the next 6 months, or even after 3 years during the second wave, it will stay there forever. We don't see this nowadays. We see lots of things that they come out of the stents, they reach the nose, or it's neoatherosclerosis or whatever it is, and I think that's due because of the thinner struts. We have thinner struts, so we have lots of neoatherosclerosis. Again, I don't say go back to the old sort of Palmasat stent, but what I'm saying is that there's always a penalty that we have to pay, and that what you usually manage is to sort of exchange one disease with another.
But neoatherosclerosis actually is first. It's more frequent with the thick strut stents, and it appears maybe 3 to 5 years before appearance of thin strut stents. Just
Yeah,
it was first appeared.
The old stents that you had put, the old stents. Usually they are very good after a long time, if they did well in the beginning.
Yes.
The new ones, I'm not so sure. I'm not saying that I've got the answer, but what I'm saying is that there's something there that which we are missing. It's a changed disease for many reasons, which possibly we don't know. But we have to think of it.
Do you think that younger cardiologists, interventional cardiologists, should be much more trained how to do PTCA than we are doing at the moment? Because I think this is a missing education.
Yes, because we have made it very easy. Almost everybody can do a case with the wires, balloons, and stents we have. And they don't see the downside. You probably do too. And we worked with 18,000-inch wires and 7 French guides all the time, 8 French guides. So limited. Yeah. So, but what can you do? You cannot bring back the old days.
No, you can't. But what you can is that we have to understand ourselves first that angioplasty is not a quick thinker and a cheap thinker. And although we have technology adds to cost, adds to effort, and adds to the time that we have to spend when we try to treat our patients, and we have to manage and struggle to achieve an optimal result if we want this to last.
Yeah. Just a technical point, because you were speaking for the risk of ischemic events about some specific lesion. Again, for bifurcation.
Yes.
When you think about what will occur, you have to avoid to put a second stent when it's not necessary.
Correct.
So use the most simple strategy. Again, also in an older trial, was desert trial by Waxman, he showed that overlapping the stent was also a factor of stent thrombosis. So we can teach to our fellows how to do better sometimes more simpler
Right.
treatment.
Yes, absolutely.